All right. Hey guys, I'm William Nicolson. I'm an intern here at UAB. Dr. Centaur was actually my attending last month at the VA, and we both kind of stumbled along this case. It was pretty fun. So we're excited to give it to you.
Okay, Vishnu, why don't you introduce yourself?
Hi, everyone. This is Vishnu. I'm a PGY2 internal medicine resident at UAB Montgomery campus. Pretty excited to be here. Thank you.
Excellent, excellent. And Noah, why don't you introduce yourself?
Hey everyone, I'm Noah. In MS4 at NYU. Lake Drew, officially going to be a resident next year, going to internal medicine.
I'm really looking forward to reading where everybody's going on Friday. Jori, for those people who don't know you, why don't you introduce yourself?
Sure. I'm Jori May. I am a benign hematologist at UAB.
Yes, she is the benign hematologist, the great benign hematologist at UAB. Okay, William, why don't you go ahead and set this up so that everybody can have learn as much as you and I did.
All righty. So we're starting off. This is an 85-year-old male with back pain that has been going on for about 2 weeks now. Do y'all want to pass medical history, or just doing chief complaint?
Just say a little bit about how bad the back pain is.
So the back pain is, again, this was started about 2 weeks ago, and it's gotten to the point that he can't get out of bed. He can't get out of his recliner without help. In fact, the reason he presented to the hospital was because he fell out of bed that day and hit his head against the coffee table.
Okay, so we'll give you some of his background, and then you'll see that'll lead to the first part of the discussion.
Right. So this gentleman had a past medical history of MGUS and then TTR amyloidosis that caused heart failure with preserved ejection fraction, and he has chronic kidney disease 3B.
All right. Well, that's quite a combination. So I guess to start out, we can ask folks kind of what they know. First, we'll talk about TTR amyloidosis. That shows up on the past medical history, and I think it's worth pausing before digging into the chief complaint to make sure we know what we're talking about.
So Vishnu, why don't you try to help us out here?
So the patient coming in with this background, I'm initially thinking about, is this a progression of MGUS causing lytic lesions in the back? And also thinking about amyloid deposition in the back or in the discs as well, causing any kind of compression and progressive paralysis. So those are my initial thoughts. And
what do you know about TTR?
So TTR, if I'm right, I don't think it's really related to the multiple myeloma related amyloidosis. It's a separate entity by itself, where there's a more like a congenital to maybe like a young adult presentation that goes on into the later part of the life, rather than being related to multiple myeloma. That's all I really know about that.
Okay, Jori, help them out.
Yeah, and that's great, Vishnu. I think you know more than you're giving yourself credit for. So you're exactly right. I guess when I think about amyloidosis, amyloidosis is kind of this broad category that describes these misfolded proteins that cause end organ damage by depositing in tissues. And there are different types of amyloidosis. The most common type that we think of is light chain amyloidosis, or AL amyloidosis, and that is associated with plasma cell disorders like multiple myeloma. But you're right, there's other types of amyloidosis, and TTR amyloidosis is one of those. And it's this transthyretin amyloidosis, which is basically a different type of protein that can deposit in organs and cause problems, and typically does deposit in the heart like it did in this patient. And there's kind of two kinds. I think you were referring to the congenital type, which is so a congenital, a mutation that is genetic that leads to kind of early development versus it's been previously called senile, which I think is an unfortunate name, but in older patients, you see a wild type version of TTR amyloid. So I think that distinction is important, that we're talking about two different processes here, that MGUS and TTR amyloid are not necessarily related processes. But when we're talking about how this all relates to back pain, Vishnu, I think you highlighted some important things for work on the bones and what could potentially be deposited in that space. Certainly your regular differential for back pain in an 85-year-old patient, there's a lot of things that this could be. But when you see MGUS, you worry about the potential for multiple myeloma with lytic lesions. You worry about a plasmacytoma that could be causing compression, all of those things. I think the TTR amyloid would be maybe less likely to involve those areas, tends to be more cardiac involvement, but it's something to think about.
So Noah, what do you know about MGUS?
Yeah, so I don't have a great background on MGUS, but my general understanding is how I compare it to multiple myeloma. So it's a similar plasma cell dyscrasia, but I don't remember the exact percentage, but I think it's less than 10% plasma cells or plasmablasts. And generally, patients don't have these CRAB symptoms. The like anemia is usually not present. They usually don't have lytic lesions in the bones. Usually don't have renal dysfunction, or at least don't fit all of the criteria to hit multiple myeloma. But there is this risk of progression. I'm not sure about the epidemiology, but I thought, this patient seems a little bit, I wonder when he was diagnosed, because I imagine every year he's had MGUS, he's at risk of progression to multiple myeloma. So that's something that would definitely, like Vishnu mentioned, would be a consideration for me. And then in terms of sort of infiltration, I'm not exactly sure whether they can have isolated lytic lesions, but that's something I would probably look up. I imagine they could have isolated symptoms that don't fit the whole criteria of multiple myeloma.
So yeah, no, you touched on some good points there. You're right. I always think of MGUS and myeloma as kind of existing on a spectrum, and we do a bad job at predicting who's really going to make the move up to myeloma. And really, I think of maybe three categories. So with MGUS, smoldering myeloma in the middle, which is a somewhat newer terminology, and then frank multiple myeloma. And you mentioned some cutoffs, and there are numbers to remember when we're making those distinctions. So patients with MGUS, you're exactly right. If we were to do a bone marrow biopsy, we expect a plasma cell percentage less than 10%. And we expect an M spike, or the amount of that monoclonal protein that's made by the monoclonal plasma cells, to be less than 3 grams. So if you have less than 10% plasma cells, less than 3 grams on your M spike, and you have 0 CRAB criteria, so you have no evidence of end organ damage, then you meet that criteria for MGUS. And there's different risk stratifications based on what protein is involved and other features of the MGUS that help us predict what is the likelihood of that patient having a progression to multiple myeloma, or with some different varieties of MGUS, even progressing to other lymphoproliferative disorders. Then you have that middle category of smoldering myeloma, where you've got a monoclonal protein that measures greater than 3 grams per deciliter, and you've got greater than 10% plasma cells in the marrow, but you still have no CRAB criteria. So you have no signs of end organ involvement, no renal dysfunction, no anemia, no bone lesions. Those people have an even higher risk of potentially transforming to multiple myeloma. Again, there's risk stratifications to help assist with that. And then we have myeloma, which is the presence of any, really any amount of that protein. And really, it hinges on having evidence of end organ damage. So we do a very thorough assessment of these patients to look for abnormalities. And we keep talking about bone lesions because would certainly tie in with a patient having back pain. But that being said, there's plenty of 85-year-old patients with MGUS that are going to be pretty prevalent in an older population. And so I would be careful to anchor on the MGUS, where it's likely that could also just be a bystander in the process.
So we have a request in the chat for the CBC and the BMP. So William, take it away.
Right. So our initial CBC, we had a hemoglobin of 6.8, a hematocrit of 21.2, white blood cell count was 6.5, and platelets were 86. For our BMP, our sodium was 136, potassium was 4.4, chloride was 100, bicarb was 18, BUN was 116, creatinine was 2.7, and his glucose was 121.
Do you have his calcium also?
I do. His calcium was 10.8.
Right. So what do we think of those labs?
So
Do we have any?
I think it's
Go
Vishnu's
ahead.
turn to
Yeah.
make comments.
Okay.
At this point, we have some information to see where this would fit into our criteria. And he has anemia. There's also some thrombocytopenia. There's definitely concern for bone marrow infiltration. A retic count would be helpful to calculate the index. And with the renal failure, and the calcium is not terribly high, but it's still a little higher than the upper normal limit. So with the presence of back pain, skeletal survey would be the next step, apart from treating the acute anemia as well if he's symptomatic.
Yeah, I think those are all great points. Again, if we're looking at this through a myeloma lens, we are seeing a lot of that standard criteria. You know, I think it would be helpful when we see people in kind of a snapshot in time to understand what his labs have looked like in the past. You know, we know he has CKD. I do wonder how that diagnosis was made. Did they exclude myeloma at that time? You know, does he have other comorbidities to explain his renal dysfunction? Same with the anemia. You know, has something changed? Is he having bleeding somewhere? Or is this kind of been a gradual downtrend that would make us concerned for marrow involvement? You know, I love the idea of a reticulocyte count. It's for me, and we've talked about this before, is kind of your most helpful tool in working up anemia. So is this that the bone marrow is not making sufficient cells, or that he's losing it somewhere? You know, I think there's still introduces a lot of unknowns here, because yes, myeloma could explain these things, but they could also be explained by a lot of other diagnoses as well.
William, could you give him the sodium and the chloride? Sodium and potassium.
I'm typing it right now. Yeah, the sodium was 136 and the potassium was 4.4.
Okay, and we had a request for the albumin. A very appropriate request because we have a calcium of 10.8.
The albumin was 3.8.
3.8?
Yes, sir.
Okay, we do have one more piece of bonus information for you. When he was in the hospital 2 months ago, he had a bone marrow.
He did have a bone marrow.
And it had not been followed up on for some reason, but we followed up on it as soon as we got it. So would you like that information, Jori?
Absolutely. I always want a bone marrow biopsy. I'm a hematologist.
So he had lambda restricted plasmacytosis with 10 to 15% of marrow cellularity via CD138. A hypercellular marrow for age, 30% overall, with tri-lineage hematopoiesis and an increase in plasma cells with focal clustering. No overt dysplasia or increase in blasts, and Congo red was negative for amyloid. They recommended correlation with flow cytometry.
Okay. So that's very helpful. So I think that, you know, that means these cell counts were probably low at that time that maybe prompted the bone marrow biopsy. And so you mentioned, so what they did in this bone marrow is they stained for plasma cells for CD138, which is the marker for plasma cells. And there seems to be a significant monoclonal population of 10 to 15%. I assume they sent flow cytometry that confirmed that those were monoclonal. If you don't have it, it's okay. I would assume that they included that. So that fits us again on this concerning spectrum of where are we now? So with greater than 10% plasma cells, this wouldn't be MGUS anymore. This would be smoldering myeloma, at least if we didn't attribute any of the end organ damage to the myeloma itself. But in the setting of anemia, which at this point we don't have another explanation for, this is certainly concerning for a new diagnosis of multiple myeloma. The Congo red staining was done, which Congo red is a general stain looking for any type of amyloid protein. It's frequently negative even in AL amyloidosis. You don't often get bone marrow involvement. So, I do wonder too a little bit about how the TTR amyloid diagnosis was made. The fact that this is lambda restricted is up to form AL amyloidosis. So there's still a lot of variables here in our understanding of this gentleman's past medical history and how that might be contributing to what's going on with him now. Yeah.
So I'm going to go ahead and challenge Noah and then Jori. Let's come up with a list of other labs that we probably got, and we're more than happy to get them for you. And then we will show you an X-ray of the back. So
I'll start with the sort of what Vishnu was first explaining and talking through differential wise. In terms of the anemia, I definitely want a retic count, but I'd also, in terms of history, I'd also want to know whether he was on iron or EPO at the time. If his hemoglobin's been consistently low, and given his CKD, he likely should be on some sort of therapy. And wondering that. In terms of his BMP, or actually I'll focus on his creatinine or the calcium for a bit. I definitely want to get a PTH. Someone mentioned in the chat that the corrected calcium is above 11.5 given the slightly low albumin. So I would definitely want to evaluate the etiology of this hypercalcemia. In terms of this metabolic acidosis, well, I guess we can't call it a metabolic acidosis yet, but because I know you'll jump on that. Yeah.
You actually can. There is an increased anion gap.
Yeah.
That's the one time you can say there is at least some anion gap acidosis. So you've done nothing wrong. You've actually done something right, Noah.
Appreciate it. And yeah, I haven't calculated the gap, but someone mentioned, thanks for there. So it's in it. That's odd because in CKD, I wouldn't necessarily jump to an elevated anion gap. And I don't know, I'd be struggling to figure out where that's coming from. Especially because we have,
so here's a general tip, since you're going to soon be an intern.
Yeah.
When you get initial mild increase in the anion gap, see whether or not, and notice the BUN to creatinine ratio, see whether or not there might just be some volume contraction, some ketosis because he's been lying in bed and can't move. Give him, see if he needs some volume resuscitation and see if it goes away. I usually don't work up anion gaps of 18.
Gotcha.
And I love anion gap, but 18, I usually don't work up. I always work up above 25, but a lot of times this resolves by the next morning. So I wouldn't get excited by that yet. Just like I wouldn't get excited about the BUN to creatinine ratio just yet. And I wouldn't even get excited about the calcium just yet until we see what's going on. I mean, I'm very interested in it, but I'm not ready to get excited about it.
Yeah, I think sort of the main workup that I'm focusing on is whether this is smoldering or florid multiple myeloma at this point. So I definitely want to get an SPEP, UPEP, and evaluate for any bony lesions, so any lytic lesions. Get some imaging. Yeah, I don't know what it's pan scan for a full skeletal survey, but I'll hand it over to Dr. May for that.
So William, maybe you can help them with where he was when he was in the hospital previously with his labs, just so that we can put them into context.
Right. So when we admitted this gentleman, I think a lot of the these similar thoughts were running through our mind. And so he was in the hospital about 3 or 4 weeks prior for a heart failure exacerbation. And so his labs were relatively similar. His creatinine, his baseline is around 2.2. And then as far as like his anemia history, he is chronically anemic. And he was diagnosed, I believe, with MGUS. I think in March of 2019 is when he had an SPEP with 2 M spikes. And then he had a bone marrow biopsy in September of 2018 that had slightly hypercellular marrow at 25%, with few plasma cells with lambda excess at 0.4%. And so this is kind of where we were. He was chronically anemic. His creatinine baseline was about 2.2, and then his calcium had been elevated for a period of time.
Right. And I'm trying to remember, I thought we gave him fluid and the anion gap came down. Is that right?
Yes, sir. I believe so.
Yeah. So I wouldn't be worried about giving him fluid because his creatinine had increased and his BUN was so out of proportion. So I would definitely give LR. So somebody put in the chat, do you worry about LR with increased potassium? There are only 44 milliequivalents of potassium in LR. So you just don't worry about that. So everybody's dying to see the back x-ray. Sean, can you show them the back x-ray?
Yeah, 1 second.
So I think this is the first time we've actually shown an x-ray in unRemarkable Labs, but we knew you'd want to see it. Go away from that. Nobody knows what that is yet. So here's the back x-ray. And we have a bunch of back x-rays. And Dr. Gaffo happens to be in the audience. Maybe he can tell us something about these back x-rays.
Yes, thanks for inviting me. What you're seeing here is a cut of the middle of the sacroiliac joints. You have here a portion of the lumbosacral spine, but that's probably it's not the right cut there. It's not very informative, but in the sacroiliac joints, you have the right one on your left, and you can see that the cortex is quite irregular, and there is a sclerosis, and in the very inferior portion of the right sacroiliac joint, there is irregularity and erosive disease. The left sacroiliac joint, this cut is not showing too much, but in the very inferior portion of the left sacroiliac joint, there is some irregularity. Now, you had some transversal views that were very informative. I don't know if you can go back to these ones. Okay, this is absolutely impressive. So normally, when you look at sacroiliac joints, you have a very smooth cortex and essentially no or little irregularity. Here, there is an impressive amount of sclerosis on the iliac side, and a lot of you can see there in the most anterior portion erosions in the cortex of the sacroiliac joint. I'm seeing in the chat that there are some questions whether this could be lytic lesions. And I can tell you these are not lytic lesions. Now, you will see lytic lesions inside the trabecular bone of the pelvis. What you're seeing here is in the cortex. The sclerosis is in the cortex. The erosions are in the cortex of the sacroiliac joints. It's these usually I usually look at these cuts when I'm looking at people with the question of ankylosing spondylitis. Now this gentleman, is way too old to have new onset ankylosing spondylitis. Yes, as someone just put in the chat right now. So what else could be going on here to cause this amount of erosions and sclerosis in the sacroiliac joints? Well, we're
going to keep that. We're going to keep that thought. So keep that thought.
Yeah.
But there are no lytic lesions in the back. We did bone survey. There's no lytic lesions. So we will bring Dr. Gaffo back for another film here in a while. Sean, if you can get us back. Jori and Noah and Vishnu, what do we think now?
With the back images, I would be thinking if this is like an erosive arthritis or something related to a deposition disease from all the paraproteins that this patient has. Yeah.
Yeah, I think we've got a couple of clues along the way that, this patient has multiple diagnoses, but it may not be explaining what's going on with him right now. I think the fact that we have the historical information that the creatinine is maybe a little bit up, but not significantly changed from when he had a bone marrow with little to no plasma cells, same with the anemia and the other cytopenias. So I'm less feeling like this is something, although the bone marrow does show this increase in plasma cells, we still are not necessarily finding any sort of CRAB criteria. I think sending labs in order to quantify that monoclonal protein is important, but then talking about what else can cause this kind of erosive finding that we're seeing within the cortex, which is not something that I commonly see. So I would start reaching out to colleagues to say, hey, this doesn't look like the hematologic process that I would expect. I feel like the MGUS is maybe a bystander, and I don't expect amyloidosis to deposit in these areas. So what else could be going on in this patient that is maybe not related to these diagnoses?
So William, did we get some of these other labs that they wanted?
So we didn't, I don't think we investigated the calcium too much. So I don't have a PTH and vitamin D with me, although they're very good points. We consulted hematology oncology when he was admitted just because of his bone marrow biopsy. And they recommended that we actually get tumor lysis labs.
Well, what's this tumor lysis lab thing, Noah?
So generally, I think more commonly in liquid tumors, but can be in a few solid tumors. I don't remember off the top of my head which solid tumors are at risk, but in liquid tumors or recently initiated chemotherapy, you can have tumor lysis syndrome, which would effectively lead you to like a hyperphosphatemic, hypocalcemic state. And then they'd be at risk of renal failure as well. So I mean, we have a hypercalcemia here, but and we have a normal potassium, but I don't know what those individual labs are actually useful for ruling out tumor lysis. So I'd probably want to get a uric acid and a phosphate to evaluate for tumor lysis. Then I guess I don't know whether MGUS or, well, I guess now smoldering myeloma would put you at risk for tumor lysis, or whether there'd be like another underlying malignancy going on.
Jori, help us here.
Yeah, so, I'm interested that my colleagues did recommend that. I mean, seeing tumor lysis in multiple myeloma is going to be pretty rare, right? So you mentioned, Noah, which is a great point. We're talking about a rapidly proliferating malignancy, or in the setting of initiation of chemotherapy, where you have kind of a rapid dying off of cancer cells that leads to these abnormal labs. So that would be unexpected. We certainly would not expect to see that in a patient with MGUS or even smoldering myeloma. This would have to be a rapidly progressing myeloma, even to a plasma cell leukemia, to see tumor lysis. So that would be unexpected. But the labs you mentioned are exactly the things that we talk about. So LDH is really going to be your most sensitive marker, right? So LDH is a non-specific marker of cell turnover. So if it's elevated, it doesn't necessarily mean that it's because of tumor lysis, but if you have tumor lysis, it's going to be elevated. So that is helpful. Uric acid too is also often a little bit difficult to interpret in the setting of CKD, right? So we do see a buildup. Those patients can have a baseline higher uric acid. So you know, if we check it and it's high, hard to necessarily know why that is, and not necessarily because of tumor lysis. But you know, this is not something where I would expect to see that.
So this at this point, this guy is in horrible pain. We've gotten palliative care, and William, you might talk about how you were treating his pain.
Right. So he had previously, I think, been prescribed oxycodone, and I think it was oxycodone 5, like every 6 hours or something. And we bumped it up to 10. And he said, this still isn't working for me. So we consulted palliative and they recommended PO Dilaudid, which actually helped his pain significantly. So we were able to kind of get his pain under control with the PO Dilaudid, but things like oxycodone were not working initially.
So then the tumor lysis labs came back. So I come in one morning and we have tumor lysis labs and everything takes a left-hand turn.
Right. So we got the tumor lysis labs. And so we already knew his calcium was 10.8, which would honestly be a little bit high for tumor lysis, but his phosphate was 5.9. His LDH, I believe, was 266. And then his uric acid was 15.2. And that got us excited. And Dr. Centaur at that point in time recommended that we call rheumatology.
So that's why Dr. Gaffo is here. Dr. Gaffo, introduce yourself and to explain to everybody what you told us and what we thought about at that point.
Yes, I'm Angelo Gaffo. Thanks for inviting me. I'm a rheumatologist in the Birmingham VA. I'm associate professor in UAB, and so we were invited to consult in this case, and well, this is a very high. We call it serum urate. When in its circulating form is urate as opposed to uric acid, but that's semantics. It's a very high value, very hyperuricemic. We have seen a gout affecting the spine and the sacroiliac joints before. It's not very common. You probably all know gout is an arthritis which tends to involve peripheral joints first, usually the first MTP in the feet, the ankles, the knees, usually lower extremity joints. This is by far the most common presentation, but not the only one. Once in a while, we see strange presentations, especially in patients that have CKD. It can be kind of more unusual presentation. So we didn't find any history of the classical history of podagra or gout involving the peripheral joints, but we actually look at that CT scan that was presented before, and we saw that there was this impressive erosive disease in the sacroiliac joints, which actually these erosions are quite consistent with gouty erosions, because you have that erosion that has it's called an overhanging edge erosion. That one where the arrow is, and what's happening there is there's a tophus usually that is radiolucent, which is sitting inside inside the cortex, and you can see actually the two edges of the cortex coming over that tophus. That's called an overhanging edge erosion. Again, most commonly seen in peripheral joints. With that with that hyperuricemia, the demographics, we thought, well, this could be this, once or twice a year case that we have of gout presenting first in the spine. And there are two ways to try to confirm this. You could ask one of your interventional radiology colleagues to try to access the sacroiliac joints with a CT-guided aspiration, or we have a novel technique, which is called a dual energy CAT scan. And the dual energy CAT scans are very cool because they are CAT scans that instead of having just one X-ray source, they have two X-ray sources, and the interaction between the two X-ray sources, the difference in the Hounsfield units in the CAT scan can actually tell you about the chemical composition of what you are scanning. So you can actually program a dual energy CAT scan to tell you if there is urate. In this case, monosodium urate, that is the insoluble form of it in the joints. And we order a dual energy CAT scan. Cool thing is that it doesn't have any contrast. So the green stuff that you're seeing in there is urate. And you can see it in that probably in the right sacroiliac, there where the arrow is. And you can see other deposits in the other post. Now, I have to confess the deposits weren't as impressive as we were expecting, but they were there. So this patient had monosodium urate deposits, and he did have those very impressive erosions. So
Gaffo froze.
Can
wait for Gaffo to unfreeze. Okay, you just unfroze.
Yes, sorry. So he has these very impressive erosions and the monosodium urate deposit in the sacroiliac joints and the extreme hyperuricemia. So we thought this was quite compelling for a gouty arthritis of the sacroiliac joints. And we decided—
Whoa. We have to see what Vishnu and Noah want to do. So what do you want to do now? This guy cannot get out of bed. He is in horrible pain. And now he's constipated because we put him on Dilaudid.
Given the severity and the location, I would tend to use steroids rather than colchicine. And at least a trial of steroids for like 5 to 7 days. And if no response, can think about intra-articular steroids also.
Do you like that, Noah?
I totally agree. I would be very hesitant to use any NSAIDs or colchicine in this patient.
With his kidney disease, you can't use the NSAIDs or colchicine. I think a while back we talked about when you want to start urate lowering drugs as well, and I think we had a debate about when to start something like I don't know which one we would start, whether it would be an allopurinol, febuxostat, or something more directly urate lowering like Resbericase in an actual flare. But I would start to ask questions and think about when we should start something, because that's a very high serum urate, and I would wonder in a patient like this when we should start that. And also just when we have sacroiliac disease, I think of it more as a sort of a knee and more peripheral joint disease. So Jori, when y'all are considering tumor lysis syndrome, you do go to Uricase quite quickly usually, don't you?
We do, because the thought is that that's being rapidly being produced so rapidly that you need to break it up as quickly as possible.
So Gaffo, tell them your genius.
So, well, in this case, you are treating a flare we saw this as a flare of possibly gout, and we gave him systemic glucocorticoids, and we started with a relatively mild dose of IV methylprednisolone and that's usually quite helpful. I agree with the judgment. NSAIDs completely contraindicated in this case. Colchicine also, I would say, almost completely contraindicated because it's not going to work first for someone who has such severe burden and so protracted, and also so hard to dose with this advanced degree of CKD. So glucocorticoids would be the way to treat these. Now, so many questions about urate lowering therapies. Yes, they need to be used. It's different if you're treating tumor lysis, of course, than you're treating gout. In tumor lysis, you want a profound and rapid reduction of urate because of effects on organs like the kidneys and things that can happen rapidly. But in gout, you want you want to reach a serum urate level of somewhere between 5 and 6. But you want to get there gradually. You don't want to. You sometimes want profound reduction. You don't want profound reductions always, because that can in itself exacerbate and create more flares. So you usually start. Our first choice now is halopurinol. There are some concerns about the cardiovascular safety of febuxostat, although that has been there's new data that is more reassuring, but still allopurinol is the first choice. I saw in the comments 50 milligrams as a starting dose. This is the dose that you will choose in someone that has advanced CKD like this patient. In a patient with normal kidney function, you will start at 100 milligrams. Then you up titrate the dose to whatever dose is needed, essentially within the dosing guidelines to reach a serum urate goal of 6 milligrams per deciliter as a standard. But in this patient that has already kind of monosodium urate deposits in tissues, I will probably aim for 5 milligrams per deciliter. Febuxostat also very useful. The uric acids, again, this is not tumor lysis, this is gout. So the one that we use is called pegloticase. Pegloticase is a more modern pegylated form of uricase. Rasburicase is very hard to use in gout because rasburicase is highly immunogenic and it's very hard to redose it. It has a very, very short half-life and it just tends to have a lot of immune reactions if you kind of redose it often. Pegloticase also has problems, but because it's pegylated, it lasts 2 weeks after infusion and it causes less reactions, although it's not completely devoid of them. This case probably is perfectly appropriate to start allopurinol because this patient has would be treated with first-line therapy like allopurinol. Systemic glucocorticoid to get him off the flare. He probably will need something for prophylaxis of gout flares, and that will be tricky in the context of having advanced CKD. Sometimes we have used IL-1 inhibitors like anakinra for that, but you could combine that with a tiny dose of colchicine, like 0.3 milligrams every other day, to try to prevent gout flares. You're not treating gout flares, but you're preventing gout flares with prophylaxis. So it's complicated.
So William, tell them what happened.
So I guess I need to give a little backstory in we were managing his pain with the PO Dilaudid, and we had it set at offer, but may refuse. And so we started the Solumedrol at, I think, 40 milligrams, and his pain was completely resolved. But it was kind of, water was a little bit muddied with the Dilaudid, so we changed it to purely PRN. And I went in the next morning, and he had not asked for a single pain pill the entire day. And he went, and then we transitioned him to PO prednisone, I think after 2 days of Solumedrol. And his pain was completely gone and completely under control with the Solumedrol and the prednisone, which had us all really excited because pretty much confirmed our thought that this was gout. And then we started him on Rasburicase as well, and we saw his urate go down from about 15 to 10 at discharge, and I think we discharged him on allopurinol.
And so And then Gaffo went back and looked, and he'd previously had hyperuricemia that nobody had apparently noticed. Is that right, Gaffo?
Yes, something that we love to do when we're studying these cases is go back and see what happened. So we basically traced the urates, and for some reason, someone, I think because I don't know if he used to go to renal clinic or some other clinic that monitors uric acid as part of the monitoring labs. I think his urate was already 8 or 8.5 in 2015. So he had been hyperuricemic for a number of years.
And that makes sense with all those erosions you found in the sacroiliac joint.
Yeah, I think it's possible that he's been hyperuricemic for a number of years, never developed gout initially. Then CKD, at some point, CKD kind of got itself established. Actually, CKD is it's interesting because CKD is partially anti-inflammatory. I know what I'm saying doesn't make a whole lot of sense, but it's been studied that patients with advanced CKD tend to have less gout flares sometimes, for at least for a period. So it's possible that he didn't develop that stage of overt podagras and flares in the ankles because his renal function was getting progressively deteriorated, and that in itself suppressed the immune response and the innate immune response to cause gout flares. And what he was basically, and what we were seeing at the end is just the end stage that happened that bypassed all the usual initial states.
So why don't we wrap this up? Jori, now that you've heard the whole case, why don't you, from a hematologist point of view, why don't you share with us what you think the big take-home points are in this man's story?
So I think for me, the key here is that patients have MGUS and it's not always myeloma, and it doesn't always explain their symptoms. That particularly in an older population, we see this diagnosis of MGUS, and we started going down that pathway, which I think was appropriate. But just this case is a great reminder that many patients have MGUS that never causes them problems. So not to fixate on that as an explanation for other symptoms, and really to explore other diagnoses.
And I would just mention that the phosphate you can explain from his kidney disease without having to blame it on tumor lysis. We were still wondering whether he had a mild amount of spontaneous tumor lysis causing that uric acid, but with the previous history that Angelo found, this probably just was gout. Angelo, what do you want us all to remember from this presentation, which was really dramatic for our team, because we had a guy who is essentially going to go on hospice because of pain. He still has many problems, but his quality of life improved thousands of % overnight.
I would like to remind everyone that gout is very common. That hyperuricemia leading to gout is also extremely common. But in patients with CKD, in adults in the extreme of age, probably over 80s, gout presentations can be sometimes atypical. It's not always going to be a classic podagra or classic redness. I mean, sometimes you could have a gout presenting in atypical ways, like sometimes symmetric polyarthritis that wasn't diagnosed previously, or in this case, kind of back pain. Honestly, probably a fraction of 1% of back pains are gout, but in a case in which you are seeing a very high level of uric acid, and you have unexplained symptoms related to back pain, or sometimes we found it in the cervical spine, it's something that can enter your differential. I am seeing a number of comments about asymptomatic hyperuricemia. We don't treat asymptomatic hyperuricemia yet. All the data about treating lowering uric acid for improving kidney function and cardiovascular function, so far all the studies have been negative, so I cannot endorse that. as high as an uric acid could be, I cannot say that you have to lower it just to improve cardiac or renal disease.
So Vishnu, now that you've heard the whole case and did a wonderful job with discussion, what are you taking home from this?
I think looking at the bigger picture, if we have multiple diseases at play, which share common manifestations, we should often delineate to see which disease is contributing to the majority of this manifestation. Like in this case, even though we have anemia, we want to know, is myeloma the bigger factor or something else is a bigger factor? And going into the details of the case itself, when something doesn't look right, get help.
Noah?
I agree with all of those learning points. I think I have two that I'm taking away. One, gout is like the syphilis of the joints. It can really do anything and present in any fashion. And then the second is really taking a step back and thinking about infiltrative diseases, because we had a lot of potential etiologies for infiltrative diseases here. And while it ended up centering on gout, I think I'm going to take a step back and think about the amyloid diseases, the plasma cell dyscrasias, and all of the other potential etiologies that can infiltrate a joint or a bone.
Sean, what did you take out of this one?
I think this one has a lot of good things that you can take home. And I think remembering that we do have these dual energy CT scans to help image joints that are hard to access can be really helpful in diagnosing gout, and made a huge difference in this guy's care.
And my take-home message for everybody is you want to be at an institution where you have great consultants like Jori May and Angelo Gaffo, because they're both extraordinarily helpful at all times when we get in these binds. Our team was absolutely shocked by the diagnosis here. But we did specifically call rheumatology because that uric acid was so high, and we said, could this be gout of the spine? Because I knew there was such a thing. But we wanted to share this case because there were so many different lab things going on, and it's sort of, for those people who took English in college, it had an O. Henry ending. So Noah appreciated that. So he must be an English scholar.
Hard